And welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters. And man, we have a great show for you.
Good morning. What is happening, man? Welcome to Tuesday Training, the show brought to you weekly here in the Insurance Syndicate, brought to you by DFY CRM, which is my CRM of choice. It's amazing how many agents I still, to this day, it's 2025. I mean, this is the future. And I still talk to insurance agents like, oh, yeah, we just put it all in an Excel spreadsheet. Super easy. Like I can keep them in columns and rows and all of that. I'm like, come on, man, you need to get a CRM. You need to get with the times. If you were out there looking for a CRM, give my buddies over at DFY a call. We are working on some fantastic stuff together. Easily one of the best white labeled versions of Go High Level that is out there. So again, if you're looking for one, give those guys a shout. They'll give you a tour and get you all set up. But man, we've got a great show today. I'm super excited. We're going to bring on a second time appearance guest, a buddy of mine that I met a couple of years ago, Nir Patel. He is with a company called Virtuous Benefits. They are I'm going to let him tell you, but basically they work in the direct primary care space. And direct primary care has very much become a disruptor in traditional health insurance, whether it's group insurance or even individual insurance. I'm starting to participate now in direct primary care with some of the local people here in Cedar Park. So it is definitely something that is growing. It's something that's disruptive, and it's something that's timely. Like, I'm not in the ACA space. I know a lot of you guys out there in the ACA space, and I know a lot of you are in the group space. Those are two areas I don't really participate in. I'm pretty much just a Medicare geek, right? But I'm talking to people that are transitioning into Medicare, that are coming out of direct primary care relationships, or they're trying to figure out like, hey, how do I get Medicare and avoid all the dumb penalties that the government wants to push on me if I don't properly enroll in Medicare? But how do I keep my direct primary care physician? How do I keep that relationship while blending it in with Medicare? And there's certainly some ways to do that. We're not going to talk about all that stuff today, but we are going to talk a little bit about certainly what direct primary care is, right? How it is disrupting the health insurance space. How you can understand it better, and how you can kind of prepare yourself to either get involved or understand how to use it as an alternative health solution for some of your clients, especially in today's ACA market. For one, I can't tell you really what's going on in the group space. Maybe the group space is just as turbulent, but certainly the ACA space has everybody up in arms right now with the subsidies basically being canceled. So we're seeing obviously health insurance premiums double or worse for a lot of folks that are looking for individual, non-group, non-Medicare health insurance. And this could be certainly a great alternative for some of those folks, right? But then how can you as an agent get involved? We're going to touch on that too. So let's get him up on the screen. What is up, my friend Nir Patel? Again, guys, this is Nir Patel, Virtuous Benefits. How you doing, sir?
I'm doing well, Tony. How about yourself?
I'm doing great, man. It's good to see you again. I appreciate you taking some time to jump on. And I feel like when I reached out to you by phone, I feel like this is probably a perfect time to get you back on the show and talk to you about what is going on in the space of direct primary care, a little bit more about what it is and how it is kind of disrupting some of the health insurance space. But if you don't mind, just take a short moment, introduce yourself, and let them know who you are and what Virtuous Benefits is.
Absolutely. Thanks for having me, Tony. My name is Nir Patel. I'm one of the co-founders of Virtuous Benefits and DirectMed DPC. DirectMed is a direct primary care practice, kind of what Tony was talking about earlier. And Virtuous Benefits is a employee benefits agency that helps businesses incorporate direct primary care into health insurance plans that they offer their staff.
Excellent. Well, in the simplest terms that you can, like, how would you describe the difference between direct primary care and, say, traditional fee-for-service models?
Yeah, there's quite a few differences. I would say the simplest way to explain direct primary care is it's the return of independent family practice in primary care
Mhm.
back to the United States, right? So decades ago, there used to be independent doctors all over the country that had their own family practices, and they started to get swallowed up by hospital systems and sort of insurance intervention between the patient doctor relationship. And so this movement that I've been a part of for the last 15 years or so is the return of that. It's doctors that are breaking away from the traditional system, don't want to bill insurances anymore, and want to just take care of their patients, care more about their patients than they do profits. Open their own practice under a membership model that's very affordable. You can think about it like affordable concierge medicine. Now they can spend time, they can listen, they can give you their cell phone number so you can reach out at night or on a weekend if you're uncomfortable or in pain. But you can start understanding what healthy is and start creating a meaningful relationship with a doctor who actually cares about you to help you reach your health objectives.
So, in kind of short, from what I got from that, it allows the doctor and the patient to have a more lengthy, deeper relationship and discussion when it comes to their health needs
Yeah.
versus the volume play that we've all gotten kind of used to, right?
Yep. Hour visits in direct primary care, communication with your doctor in between visits through texting, calling, video calling. So yeah, absolutely. Much deeper relationship with your doctor. And that's how doctors can take good care of patients, by knowing them and knowing everything about them.
So, other than just like say the relationship or the time, like what other problems would you say that are existing in healthcare does DPC solve?
In the traditional model of primary care, lasting for 7 to 15 minutes, those doctors are incentivized, unfortunately, just to keep you sick, right? Because they want to keep you coming in every 3 months. They want to keep hitting your insurance over and over again. And the only way they can keep you coming in is to kind of keep you sick. And so those doctors are incentivized to spend 7 minutes with you at every visit, give you a medicine you might not need, send you to a specialist for something they might know how to do if they had an extra 30 minutes with you. And so in direct primary care, we're actually despecializing, right? So we're not
Mm.
sending patients to specialists for everything. Family doctors are trained to handle 90% of people's care. And it's just the time that's lacking. So when they have an hour at every visit, they can actually do a lot of the things that they're sending people to specialists for. They can also have discussions with you about your social interactions, your mental health, your lifestyle, things that can help get to the root cause of or the underlying issue of what's going on, rather than just trying to give somebody a pill for something that has a cost associated with it and also has side effects usually. So we're catching things earlier, we're keeping people proactively healthy.
How do you think we got to the space that we're in right now with some of the problem, with some of the things you're describing, like where doctors are now, instead of trying to cure, right, they're just treating, they're trying to create repeat customers in some model. Um, how did we get here, do you think?
Yeah, I actually have 40 physicians in my family. I grew up around medicine my whole life. I kind of watched my aunts and uncles have their own private practices and then start to kind of sell out to the hospital systems and become employed physicians and things like that. And so I feel like I kind of lived it and saw it happen, in my 40 years of life. And so, kind of in the mid 90s was when I saw the insurance reform starting to happen, and insurance companies stepping in between the doctor patient relationship. And I think what happened is just the business people realized that the doctors aren't monetizing this the way that they feel that they could. And so they decided, doctors aren't really the business people that we need, you know, behind the financial aspect of this, and they're not really monetizing it to its fullest potential. And so we're going to get involved, and we're going to help the doctors, sort of monetize this. And that just turned into the doctors becoming sort of the pawns of the healthcare system we live in today, and the administrators and the business people is really who's lining their pockets in this industry.
So, did direct primary care, did that kind of come from doctors who were tired of that system?
Absolutely. Every single DPC doctor in the country that I know has a very similar story to they were forcing me to see 20, 30, 40 patients a day, spending 5 minutes with each patient while somebody's crying in the room, telling me something traumatic. I have to have my hand on the door trying to get out of the room, or I have to bang on the computer to put in codes that has nothing to do with this patient's care, but won't get me a reimbursement from an insurance company unless I do it. And I'm sick and tired of that, and I'm not doing that anymore.
I can definitely understand that, some of that frustration. So for and I know you kind of focus more on the group side of direct primary care. Is that correct?
Yes. So my wife is a direct primary care physician. And so we have a practice in Central Texas that takes care of retail patients as well as employer patients.
Okay.
And so on the retail side, we do a lot of different things, social media, community outreach, and all that to educate our communities. On the employer side, that's kind of what led me to found Virtuous Benefits, was to start teaching employers, hey, you guys don't have to kind of be stuck in the same old Blue Cross, United, Aetna, Cigna situation that you seem to be frustrated with. There are other solutions out there where we can create custom insurance plans that are still ACA compliant, that allow us to build direct primary care in and help health benefits become an asset to your company rather than a liability.
And I would assume that there is probably a cost savings across the board. Like I would think in a model like this where we're getting more down to the crux. I mean, at least in theory, right? We're saying that the doctor is able to spend more time with the prospect or the client. They're able to get down to more of the nitty gritty in the crux. They're not having to send them to all these different specialists. So I assume there's a cost savings experienced by the healthcare patient, right? But then there's probably also a cost savings experienced at the employer level too, at least in that group space.
Of course, yeah. So a couple of fundamental things I would say that Virtuous Benefits does differently than most of the traditional insurance industry on the group side is, number one, we remove networks from health insurance plans. So there is no Blue Cross network, there's no United Healthcare network, there's no network at all. There's no network restrictions and there's no network contracts. So for the employee, they can go anywhere they'd like for care, and we're going to pay providers and facilities money because that's what they take. For the health plan, the greed is removed because the greed is all in the network contracts. The network contracts that we're being forced to use every time we hand over our Blue Cross card somewhere is allowing that carrier to overinflate the cost of whatever healthcare service we're getting and pay themselves off the claims. And so if those network contracts are removed, now we're able to pay the actual price of something, the self-pay price, which is generally 10 to 20 times less than the Blue Cross
10
price.
to 20 times less.
10 to 20 times less.
Is that so? When you're talking about removing some of these network contracts or whatever, would you loosely describe that as the middlemen? Like we're removing some of these middlemen from the transaction, so to speak, or the experience, and that's where a lot of the inflated healthcare costs are coming from. Is that kind of more of in layman's terms?
Absolutely, yeah. We're the middlemen that we're removing are the carrier contracts, which allow the carrier to make money off of our claims.
Who does this negatively affect other than the the traditional insurance carriers?
The traditional
Hospital
insurance.
systems? I mean, is there anybody that you're disrupting that other than because I can see how an insurance company, right, a major medical company like a Blue Cross or an Aetna or whoever it is would be somewhat or disrupted and probably hit in their marketplace by you. But what about like hospital systems? Like, are there anybody that is against you? It's like, no, we can't let this DPC thing grow.
I would say so. Hospital systems are actually positively affected by our change. They just don't realize it until they start working with us. Because when they get handed an insurance card that has no recognized logo on it, they have no idea when they're going to get paid, how much they're going to get paid, right? And so everybody's got their guard up until they start working with us. We actually handle claims on the front end. So we say, you know what, you don't even need to file a claim. We're just going to pay you right now. How much is it for this or that? right? And so once they realize, oh, these guys are just going to pay us and we don't have to wait 6 months and get nickeled and dimed and get a check for however much the insurance company wants to send us, perfect. Yeah, we'll give you a discount. We'll take the money right now. And so I would say insurance agents and brokers might be the other party that's negatively affected because they don't understand any of this, and it's hard for them to grasp their minds around, why would I move away from sort of the beast that's been feeding me for so long, right? Um, so that's I think that's the other party that's being affected.
And totally makes sense. Do you think ultimately DPC could or should fully replace traditional insurance?
No.
No.
DPC is not a form of insurance. Every doctor in the country that's doing it will be very clearly explicit about that. They are primary care doctors that are taking medicine back into their own hands for that 80 to 90% of things that they're trained to take care of. But they are very well aware that there's 10 to 20% of things that I'm not trained to take care of, and that's where people need additional coverage.
Makes sense. Makes sense. So if we're building a system that's going to help us reduce middlemen, right, reduce some of the inflated cost of healthcare to make it more affordable for us as the patient, make it more affordable for the group or employer, how viably or economically scalable, right, at a national level do you feel like DPC probably is?
I think it's very well scalable, and I think a lot of the sort of first generation doctors that started DPC, 15, 20 years ago, are teaching a lot of the, sort of second and third generation doctors that are newer into the model on how to do this, how to scale. Every doctor caps at a very small number of patients, a fraction of the number of patients that an insurance PCP would cap at.
Mm-hmm.
So direct primary care doctors cap around 600 patients, where an insurance PCP will cap around like 4,000. And so the DPC practices from the first generation are all growing, including my wife's, right? We started from scratch with 0 patients back in 2015. We now have 6 physicians and 3 locations between Austin and San Antonio. Many other DPC practices have done similar things where they've continued to grow. As soon as you get a few hundred patients on your doctor's panel, it's time to look for another doctor. And doctors, if there were patients waiting for them to do direct primary care, they'd quit their job immediately. So it's kind of the chicken or the egg thing. It's like the doctors are worried about leaving their job in the traditional system and that salary that comes with it. And then how do they get patients, right? That's what they're worried about. And so that's the other thing Virtuous Benefits is helping doing, is kind of getting into the employer space to have a constant stream of patients for all these doctors to be able to say, now I feel comfortable leaving the traditional system because I can see the light of how I can get patients.
So your focus within Virtuous Benefits is more in finding the physicians that are looking to participate within your DPC in your program, or?
We absolutely do that, right? So every group that we onboard, we have DPC incorporated in their health plans, and then we put everybody on a map, and then we go out and find the DPCs that we're going to pair up with every member that's kind of on our health plan. Those DPCs already exist. For the last 15 years I've been in this space, there's been new DPC practices opening every single month. It has not stopped. So like I said, doctors are not happy working for insurance companies. They do a very good job of hiding it, but they are absolutely miserable, being these pawns for these insurance companies and sort of all this profit work rather than patient care work. And so as soon as they see a path where, my loans are paid off, now, I've got some breathing room. I talked to these 5 other doctors that have been doing it for a couple of years. I know I have a plan on kind of how I'm going to get started and how I'm going to get patients. I'm going to go ahead and do this. And that's been happening every single month.
Yeah, I never really knew what direct primary care was until I actually met you a couple of years ago. Like, just no clue. Like, I didn't realize that you could just go and get a membership with the direct primary care group in your neighborhood or somewhere and start using them instead of some of the alternatives. And I've known, like, the prices, they're not bad. Like, I've noticed they range anywhere from probably like $90 to $300, depending on the level of concierge care that you're getting, so to speak, right? And what they're doing. But I'm kind of curious, like you've been doing it for a while. So like what outcomes or improvements maybe have you seen on a consistent basis with people, with the population that's using DPC versus maybe some that aren't?
Sure. Yeah. So, I mean, I can speak for our own patients in my wife's practice. You know that she's been running for over 10 years. Uh, just the turnover itself, being almost non-existent, kind of tells you, right, that these patients see tremendous value. Some of the, the reviews, the thank yous, the gifts that we get from patients that are like, you have helped me so much more than any doctor that I've ever been with, with helping me kind of figure out these unexplained issues that I've been passed along between specialist to specialist and doctor to doctor, and nobody has been able to figure out. You just were able to spend time to listen to me and help me figure out like what's going on and how do we turn this in the right direction. So just all those patient outcomes and those stories, those reviews, just all the things. If you look at direct primary care practices all around the country and you look at their reviews, they're pretty much 5-star across the board, across the country. And there's nothing different about these doctors. They didn't go to different medical schools. They didn't go to different residency training. They just are practicing in a different model, in a different setting that allows them to be that community doctor again, to know their patients, to know their community, to help people get healthier, know what healthy is, and stay healthy. And that's really what the difference is with DPC.
Absolutely. Do you know, or could you share maybe a real world example of where you've seen direct primary care prevent maybe a health catastrophe or some major grotesque claim situation?
Yeah, absolutely. Funny that you asked that. We have a company, a law firm. Actually, they're based here in Round Rock, and they have employees kind of spread out all over the country. They have 4 or 5 different offices around the country, and so we've got pretty much everybody at that company on a DPC health insurance plan. They're all paired up with DPC doctors wherever they're located around the country. One of their employees happens to be a patient of my wife's practice here in San Marcos. And when she came into our health plan, she was on a drug called Humira, which I'm
Hmm.
sure a lot of people have heard of. It's very
Especially
expensive.
in this group. Absolutely.
Yeah. And so we sort of intervened immediately with the health plan. We started to do what's called personal importation. So we can source specialty drugs from other countries where they're manufactured. So the
Okay.
drug manufacturers have plants all over the world, and we can source these drugs directly from those plants. And so we started sourcing the drug from Canada, I believe, and we were able to get it for like 80% off the U.S. retail price. We then were able to get our pharmacists involved. We have pharmacists in our health plans to start looking at alternates that treat the same way but cost less, right? And so there's a biosimilar called
Hmm.
Abrelata, and then another one called Yusimry. And so we were able to kind of stair step this patient down from Humira to Abrelata to Yusimry and save, another 50, 60% after the 80% that we started with. So we got the drug down to a manageable cost for the health plan. But the patient was like, I really wish I didn't have to take this medicine. This medicine compromises my immune system and it just makes me feel weak and gives me side effects and, all these other things. She was getting it for free. When in our health plans, when we're doing personal importation, the member gets everything for free. They don't have a copay, they don't have a cost for anything, and it gets delivered to their home. So this wasn't an inconvenience. This wasn't a financial thing. She just wanted to feel better, and she just wanted to not have to take medicine if possible. And so her DPC doctor, Dr. Beth Just, has training and experience sort of working with patients and helping them with some of these autoimmune conditions that exist and getting off of some of these immunocompromising drugs. And so she kind of said, you know what? I'm not going to give any guarantees, but I feel like I can work with this patient and I can help her start going in a different direction and maybe get her off this drug, right? And I'm already got some ideas of some cocktail kind of drug cocktails that I think I can start her on to start to help her wean off of this drug. And she worked with her for a full year. The full year, that first year of that health plan, we were taking care of that group. And by the end of that year, um, and working with these drug cocktails, she was able to finally get this patient completely off of that specialty medication. And so the patient's feeling great. We did the second year's open enrollment this summer, and that patient decided to stand up at that meeting and speak about her experience in getting off of that very expensive but very life-saving drug. And so that was a real win that I saw. That is not a normal thing. DPC family doctors don't usually have experience working with patients of that complexity and on those types of, very expensive specialty drugs. But we just happened to find a unicorn in the DPC world that had that training and experience and felt comfortable doing that. And the patient, is in a much better place today because of it.
This made me think, is there any legitimate or standing argument between doctors that are in the DPC space versus physicians and doctors that are not in the DPC space, right? Do they have a point of contention that they're like, well, you're going over there because you can't, I don't know, handle X, Y, and Z, all right? Or you're going to open people up to experimental stuff that may or may not actually be good for them, just because you want to be able to spend an hour thinking and pontificating your own possible way, where we're following, specific medical guidelines, processes, and rules over here, or vice versa. Like I totally get the idea of wanting to spend more time with my doctor, and a doctor wanting to be able to give what they feel is much better care. But I'm curious if there's a point of contention between that two sets of physicians that they argue with each other over.
I wouldn't say that there's a like a generalized contention between the two groups. I think, when you're dealing with this subset of human beings, you're always going to have different personalities and different opinions and things like that. And the people, the physicians that are working in the traditional system, no doubt are extremely stressed every single day. And so that also causes, venting and just taking things out on people that, that just because there's something else that might be bothering you. But yeah, I wouldn't say it's a generalized, I would say most of the physicians in the traditional system probably envy the direct primary care doctors and say, I really wish I could be doing that. And I think that's how this model continues to grow, is more and more traditional doctors find out about it and then start to learn about it and figure out a plan on how they can do it. But you're always going to have the one or two people that, just have a chip on their shoulder and are like,
Sure.
you guys are cherry picking patients. You're capping at such a small number of patients that you can't take. How can you take care of your community? There's kind of every excuse in the book that I've heard around that, and most of it is just simply not true. I mean, the model has kind of proven itself. Like, yes, we're capping at smaller numbers of patients, but we're hiring more and more physicians to continue to be able to take care of those patients.
Right. Where does service at a DPC level with the beneficiary, where does it end? Like, what can't you do at a DPC model that maybe traditional can do?
Sure. So that's a great question that I don't think I've ever been asked before. What can a DPC doctor do that a traditional doctor can't do? Was that the question?
Other way.
Other way.
What?
So,
Yeah.
okay.
So
What can a
what are the
traditional
limits
doctor?
of DPC? Like, I can get certainly my primary care. I would assume maybe some level of acute care. I don't necessarily need an extensive group of specialists, because some of that specialized care I can still get with my DPC because they are spending more time with me, right? Or they're able to produce health outcomes that maybe where I don't need certain specialists. But where does that end? Like, what level of care do I'm like, okay, I can't get this at a DPC. Now I have to go and do something else.
Sure. I would say if we're talking about primary care, traditional primary care versus direct primary care, I don't think there's anything that a traditional primary care doctor can do that a direct primary care doctor can't do. I don't think there's anything. I think it's the opposite, right? Because the traditional doctors, I mean, the most I've ever heard of traditional doctors spending with someone is maybe 20 or 30 minutes. I mean, that's the shortest visit with a DPC doctor. So when it comes, I mean, they're trained exactly the same way. There's nothing different about their medical school education, about the residency train. They're trained exactly the same way. So it really just comes down to what time do you have, what equipment do you have. They keep the same equipment in both offices. Medical supplies, EKG machines, stethoscopes, ear, otoscopes, all those things, right? They have all the same equipment. So it's really just comes down to the time, right? And the direct primary care doctors have more time, so they can do more things for you. If you need things like IV fluids and things like I mean, those are kind of like urgent care ER type situations where you're severely dehydrated and you need fluids and you need to go to the ER to do that. Some DPC doctors can do that kind of stuff in their office.
Okay.
Additional primary care doctors wouldn't do those kinds of things in their offices. They would send
Certainly.
you for that.
Yeah, the most time I've ever spent, and this is 100%, the most time I've ever spent with my primary care physician, at least my previous one, was probably about 12 to 15 minutes. And that one was when he was cutting a skin tag off the back of my thigh. Other than that, it was like, hey, how you doing? Cool, blah, 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 blah. All right, nurse is going to come in here and do blah, blah, blah. We'll see you next time. Don't forget to pick up your prescription on the way out. Like that was the standard visit almost every time I walked in to see that guy. And I even remember like going with my wife to see her PCP when we were trying to get pregnant, 15 years ago, 10, 12 years ago. And just the limited amount of time that he actually ever spent dealing with anything. It was mostly he would come in to see you face to face, go over the chart, talk to you a little bit. Oh, how was this? How did that go for you? Okay, well, here's what we're going to do. All right, perfect. I'll have the nurse come in. And then he's gone. And we've all, like a lot of us have known this for a long time, that doctors are stuck in this wild revolving door volume play. And then as we were talking about some of it a second ago, like it made me realize you were mentioning the stress, the amount of stress that those traditional fee-for-service and hospital system doctors are under. And it made me think that like, wow, if they're having to move at that speed and that volume of patients, like 4,000 versus like 500 to 600 people, the opportunity for mistakes to come in. A mistake in healthcare obviously could cost you your life, but like what it could unravel is amazing. So,
you're spot on.
Yeah. So I would, from that angle alone, like I can see how DPC is more likely, just from a mathematical, looking at it from that angle, less likely to create problems, less likely to have mistakes, more likely to increase better health outcomes. It just, from a math model, that makes sense to me.
Absolutely.
Are there any regulations that are standing in y'all's way? Like, is anybody out there pushing regulation that stifles DPC, or is anybody pushing legislation that would increase adoption of it?
Yeah, I think it's been more of the latter. And so, as we've kind of been navigating the big, beautiful bill that's about to start in 2026 and, what the current administration has done, it seems like they're supporting this movement and they're creating laws that are allowing people to have better access to good direct primary care, right? By now allowing HSA funds and making it very clear in the IRS language that, starting in 2026, people can use their HSA funds to pay for their DPC memberships. That is a huge win for the direct primary care community. We've been wanting something like that for many, many years. And so now that's going to give access to so many people to be able to say, I'm gonna use my tax-free dollars to be able to get better care, better access, keep myself healthy long term, and have this relationship with this doctor that actually cares about me.
Makes sense. So if I'm an individual and I'm like, man, I'm looking at these new ACA premiums, right? They're coming out because we don't have any subsidies, and there's rumor that they're going to extend them for another 2 years. And then there's a rumor that, no, that's not true either. Like, we don't know yet what's going to happen there. But right now, everybody is realistically seeing some pretty sizable increases. Like, I saw what mine looks like. Not super happy about it. It is what it is. So if I'm a beneficiary and I'm looking at that and I'm like, man, There's got to be something different. Like, why do I have to pay $2,500 a month to have a $10,000 deductible major medical plan with Blue Cross or Aetna, whoever it is? There's got to be something else for me, right? So they look at DPC and they're like, okay, so I can get a membership over here. Maybe it costs me $100, maybe it's $150 a month. I can schedule an appointment with my primary care physician anytime I want. Basically, they're going to spend 30 minutes on the short end with me, probably closer to an hour with me. I can get pretty much everything that I need done for the most part there, more even a lot of my specialty services. I never pay when I go in because my payment is just in my membership fee, right?
You got it.
If I get prescribed something, then maybe I have some co-payments or something there, right? So possibly I need some kind of pharmacy coverage to help me out if I do have some prescriptions. Ultimately, go ahead.
Yeah, I was gonna say possibly. So here in Texas, yes, we need, we need some form of coverage for expensive medications, right? Most generics, I would say there's 1,000 or so drugs that, don't cost very much. They cost a lot of times less than the $20 copay you have on your insurance. So you walk into the pharmacy, you say, hey, I'm just a cash patient, or you go on GoodRx or Single Care and you get the coupon and you're getting it for, pennies on the dollar. Most medications can be covered that way, but yes, for expensive specialty medications and things like that, that's where we sort of need that coverage. And people can get these meds, from other countries as well. The DPC doctors are helping their retail patients get these meds from Canada and other countries as well. So, so those options are out there for everybody.
Yeah, we work some of those same loopholes or sources in the Medicare space as well, right? Because not every drug is out there is covered under a Medicare plan's formulary. So I'm teaching them how to be a cash patient, use GoodRx, go to Canadian Med Pharmacy, whatever you got to do, et cetera. So those same things. We had a question come in from the group that was, how can agents be paid to enroll clients or businesses into DPC? Is that an option? Is that on the table?
Yeah. So the direct primary care doctors are all doing this, right? They've got memberships, like you said, they range from, I would say, 75 to, $125, $150, something like that. There's not a whole lot of room. I mean, they're doing an enormous amount of work for that membership fee. There's not a whole lot of room for them to sort of build in commissions for agents in a DPC membership. So you're probably never going to see that from a direct primary care practice. But working with forward-thinking agencies like Virtuous Benefits, right? That's absolutely something that's on the table. We work with many producers around the country, different brokers and agents that want to become producers of ours and want to promote what we're doing to their clients because they believe in that what we're doing is the future of health insurance for group health. So absolutely reach out to us. We'd be happy to have a conversation with you, talk to you about what it looks like to work with us and bring this model to your clients to help them save money and get better care and access for their staff. So
if in the group setting, like when you find out of curiosity, what's the ideal size group?
I would say
ideal size.
I would say probably under 2,000 right now. If we're kind of looking at the high end, most of what we're doing would be under 500.
Okay.
I think that's probably a reasonable amount right now based on the amount of DPC that's out there. As more and more and more DPC practices start flooding the U.S., we're going to start seeing much larger employers getting on board with this. But right now, I would say that sort of 2 to 2,000 is probably the right number.
So our groups, companies, right? Our companies that have large groups of employees, 500, whatever it is, are they replacing their group insurance with DPC, or is it more of an integration?
They're replacing, it's an integration, but they're replacing their network group insurances with open access.
Okay.
Self-funded insurances.
Makes sense. Makes sense completely. Excellent. Well, man, I definitely appreciate you stopping on. We don't have any other new questions coming in. I was kind of curious what how should a broker, right, rethink maybe their approach if they're talking to someone, like, because you hit the nail on the head. Like, there's going to be agents out there that are dealing with clients that have heard about direct primary care, right? They've heard about it. They know it's out there. They're like, well, I could get this ACA plan, or I could do this. But there's this direct primary care clinic in Cedar Park. They only want $95 a month for me to go see them. How would you advise an agent to answer that question when Margaret comes to him? Is like, why should I pay $1,800 for this plan if I can go over there and get care from them for $95 a month?
I would, as an agent, I would absolutely encourage your clients to explore, try DPC. That's going to enhance the value that you're providing to your client by making them aware of direct primary care. Once they experience that care, that access, that affordability, they're going to look at you as the hero for sending them in that direction. You don't need a rich plan generally when you have a direct primary care membership, because that membership is covering almost 90% of the care that you need. So you can start shifting your consulting for your clients to things that are more catastrophic, but also more affordable. So that's really what I would recommend: is get your patients something that covers them. They end up in the hospital, they get cancer, they need a major surgery, right? All those kinds of things that are expensive that we need insurance to help us with. Those are the things that you want to help get your clients into, and try to get them the lowest premiums possible, because the DPC is going to handle the rest of it. And you're going to look like the hero for pointing that out to them.
Makes sense. Makes sense. Well, man, I really appreciate you taking time to stop by today. If agents wanted to reach out to you, if anybody's interested in hearing more about Virtuous Benefits, because we got some group agents in here that might be interested in chatting with you guys on how they can maybe help some of their groups as well. Would that be a topic of conversation that's open?
We would love to hear from any agents that are just frustrated with, I don't enjoy giving my clients the bad news every year that their Blue Cross, their United's going up 10, 20, 30, 40%, and just doing the same old rigmarole year after year after year. I don't enjoy that. I want to do something different. I want the renewal meetings to be fun.
Right.
I want to tell them, hey, you guys didn't use the insurance, so you're getting this much money back. And I want to hear the stories about people saying, I love my doctor. This is the greatest insurance plan I've ever had because of the doctor they've given me, right? If you want to kind of turn that around and start having those kinds of meetings with clients, please reach out to us. You can go to our website, virtuousbenefits.care, live chat with us there, fill out our contact form. We'd love to hear from you, and we'd love to kind of educate you on this model and how to work with us.
Definitely. Well, man, thank you so must for stopping by. This has been very informative. We've definitely had a couple of good questions, great intention in the group. So thank you again. Virtuousbenefitscare.com.
Virtuousbenefits.care.
Virtuousbenefits.care. There you have it. We'll make sure that link is in the group as well and in the thread for anybody that wants to look it up. Thank you guys for tuning in. This has been another solid Tuesday training here from Nir Patel. Man, I hope to catch up with you soon on the flip side, but thank you so much for stopping by. And again, thank you guys for tuning in.
Always great to talk with you, Tony. Thanks so much for having me.
You got it, buddy.